Thank you, Dan, for the introduction. No giraffe picture in my presentation. No disclosure. I think in decision for how to treat patients are a complex decision. It's not a yes and no decision. You have to consider everything. We talked about IFU, we talked about other technology, but I think from my talk, I want you to understand how to do open repair, and open repair might be an option for two reasons. One would be for limitation of endovascular, and in some other patients, even if they're younger, perhaps with better durability in open repair. We know that AAA is common in people older than 50 years old. There's been a shift of endovascular repair for open surgery, there's a shift in aortic repair in the United States toward endovascular in the last 2 decades, as you can see in these pictures. And this was based on more and more technology and how we got better in performing endovascular repair. And we see the same patterns globally. This shows that in Canada, there's more endovascular repair compared to open surgery. So the other thing that I wanted to touch is overall mortality. We're trying to treat aneurysm to decrease mortality. And we know that overall mortality of AAA going down. And this is based on medical management, actually, the blood pressure control, cholesterol management, smoking, and BMI, and to some extent, perhaps for a surgical intervention that we are performing. When you are looking at a treatment modality, a factor that we should consider to offer a treatment modality, we should, including open or endovascular repair of aneurysm, we should think of what is the risk of rupture. Is this patient has risk of rupture, or what are the operative risks, whether it's endovascular or open. These operative risks you can divide it in patient factors and surgeon and hospital factors. And also, what are the anatomical limitations? How is the neck? How is angulated, or is it not angulated? And calcium, thrombus, so there are other factors. And the other thing that you have to pay attention is what is the life expectancy of patient? Is the patient a younger 50-year-old or somebody who's 90 years old with less life expectancy? And also, the patient preference is important. So it's a very complex algorithm that we all consider every time we make a decision. And I don't think it's a yes and no. So as far as the rupture risk, we talked about this in the past. We know that the aneurysm, the diameter is the surrogate of rupture, and we know for greater than 6 centimeter, there's increased risk of rupture, and perhaps for less than 5 centimeter, there are multiple trials showed that surveillance versus open or endovascular repair are the same. So we don't consider anything for aneurysm less than 5 centimeter. And this is slide I wanted to also emphasize that it's not only the diameter, the other factors such as expansion, family history, hypertension, COPD, and the shape of aneurysm important. For less than 5 centimeter aneurysm, open or endovascular, do as good as surveillance, so you don't really offer that to the patient. The reason that we talk about open or endovascular comes down to, if you don't perform surgery, obviously the risk of rupture is there, but from open or endovascular surgery, there's perioperative risk for asymptomatic or symptomatic patient, as discussed here. So there is risk of, for both open or endovascular, the perioperative risk of treating these asymptomatic patients. So looking at patient factors now. What are the predictors of mortality in patients? These are things that we all know. The cardiac risk factor, congestive heart failure, coronary artery disease, CKD is important. These are things that would increase the mortality, preoperative mortality, advanced age, and also hospital and surgeon volumes are important, we know. And then we talked about anatomical limitations for EVAR. We talked about hostile neck, short neck, wide neck, conical neck, angulate neck. Thrombus and calcium was also important. So somebody who has a lot of limitation for anatomically or surgically or patient-related for open or endo, we have to consider those. So when we think about open aneurysm repair, When these anatomical factors are present for EVAR, and the neck is hostile, they have multiple renal arteries, there's inadequate access, or some other factors such as infected aneurysm, infected EVAR graft in the past, or a failed EVAR, and some other special cases like short horseshoe kidney or inflammatory or congenital. So you, again, open repair is not the only option, but you have to pay attention and you have to consider that in certain cases. How to do open repair is also important. We are going through a paradigm of people who are training or not getting exposed to open repair, especially these cases are always harder cases. They are not really straightforward cases. This is a case that presented to us with infection, and we performed extraction. And these cases are hard. You have to have suprarenal control, supraceliac control, have to extract the stent out, and I prefer to perform inline reconstruction with rifampin soak as we did in this case. You try to do these cases early in the morning. You have to make sure that you have enough help, and these patients usually require lifelong antibiotics, and there are some of these patients that come back with reinfection down the line. Access to renal artery was a case that Dr. Stasiopoulos showed. A patient who are younger, 58-year-old male with 5.5 centimeter AAA with an access to renal artery. This patient, we decided to perform open repair with reimplantation of the the left renal artery. This is similar to Dr. Viyuka's case. This is 83 years old patient with 14 centimeter 14 centimeter aneurysm with very angulated. I didn't consider endo. Perhaps I could have placed a Gore graft, but as Dr. Viyuka was saying, this aneurysm was shifted all the way to the right side. We were able to. You probably can do endo, but to my surprise, the whole open repair took less than 2 hours. We placed a tube graft. You can see from here, the proximal neck was in left upper quadrant almost. So, and patient did well and was sent home. So, not all angulated necks are safe to do endovascular. And I don't say that. I think the technology is going to get better and better, but you have to consider open too. These are the patients that we talk about so far. Was the patient that were outside IFU. We talk about limitation, but how about survival overall for patients who are not outside IFU? And more trials are showing that perhaps EVAR initially has a better perioperative survival, but in long term, the Kaplan-Meier cross, and perhaps open repair has better long-term patency, better long-term survival, even in patients who have or not, who don't have limitations. So that's another factor to think about. The recent look at VQI from these authors showed that patients who actually underwent EVAR greater than 80 years old did worse than open, and patients who did underwent open were less than 65 years old did better. And the risk factor were the common risk factor, CHF, CAD, and GFR. So, and then also we talked about volumes important. Open repair, you have to do it. And if you are not familiar with open repair, you have to call people who are more senior and can perhaps do surgery, and you do it where you have enough support. Talking about rupture, open versus endo for rupture, this is a review from the time I was at Cleveland, 160 patients who underwent rupture repair. The quarter had EVAR, the other 3/4 had endo. This is back from 2008, so a lot of open repair in 2008. But mortality was the same, but we saw the same pattern that the line crossed after 2 years. So perhaps more and more trials show that perhaps EVAR, open repair, is probably more durable for people who have long life expectancy. So how do we do it? They're transperitoneal or retroperitoneal. A lot of people do transperitoneal because it's rapid, easy access. That's my preference. You have to know exactly where you're going to clamp. Look at the imaging before the renal vein. You have to mobilize the renal vein. If you have to ligate the adrenal, is okay. But if you're going to go supraciliac, probably better to go retroperitoneal. The other thing is IMA. A lot of times IMA is occluded, doesn't need to be reimplanted, but you have to consider that too. And there are special cases such as inflammatory aneurysm, which probably perhaps do better with endo, but horseshoe kidney probably do better with open. So my algorithm, and this is like kind of summarizes that. When I see a patient who is a good endo candidate and is not an open candidate, I do for EVAR first. Vice versa, if the patient is not a good endo candidate, but an excellent open candidate, we do open repair. The gray zone is when they are candidate for both. The good open candidate or endo candidate, perhaps we can do more open in these patient population. And if they are not a candidate for any of these, you should probably do palliative or medicine, so medical management. So this is sort of my talk. I think in summary, I think we are going to get better and better. Operative mortality, probably perioperative mortality is equivalent in both EVAR and open, but probably we don't really know which endo candidates are high-risk patients are poorly defined. Probably EVAR is better than open for rupture, but long-term survival is probably superior in open candidate.